prayers.
Let us pray. Let us, Lord, in all our doings with your gracious favor, further to your continual help. That in all our works begun, continued, and ended in you, we may glorify your holy name, and finally by mercy attain everlasting life, through Jesus Christ our Lord. Amen. Almighty God, our Heavenly Father, send forth, we beseech thee, upon thy servants who bear office in this country, the spirit of charity and justice, that they may in all things walk before thee with steadfast purpose and a single heart, and faithfully serve in their several offices, through Jesus Christ our Lord. Amen. And let us continue to pray for protection during this hurricane season. Heavenly Father, we live in the shadow of powerful elements beyond our control. We ask that you stretch out your mighty hand to protect us, our families, our homes, from the devastation of storms and hurricanes. Calm the storms that may threaten our shores. Ease the anxiety and fear in our hearts, and replace them with an abiding trust in your peace and mercy. Grant wisdom to our community leaders and courage to our first responders who stand ready to help those in need. Watch over all who live in the path of the tempest. Keep us safe in your shelter and help us to remain steadfast and supportive of one another. In your holy name we pray. Amen. Merciful God, author of all good things, we humbly beseech thee for the Parliament of Barbados, especially the Senate at this time assembled, that thou wouldst be pleased to direct and prosper all their counsels to the advancement of thy glory, the good of thy church, and the safety, honor, and welfare of our people. All this we ask in the name of Jesus Christ, our most blessed Lord and Savior. Amen. Together the Lord's Prayer. Our Father, who art in heaven, hallowed be thy name. Thy kingdom come. Thy will be done on earth as it is in heaven. Give us this day our daily bread, and forgive us our trespasses, as we forgive them that trespass against us. And lead us not into temptation, but deliver us from evil. For thine is the kingdom, the power, and the glory, forever and ever. Amen. And may the grace of our Lord Jesus Christ, the love of God, and the fellowship of the Holy Spirit be with us all now and forever. Amen.
The Senate is in session.
Messages from His Excellency the President. Announcements by Your Honour.
Minutes of our meeting held on Wednesday, 17th of June, 2026. Senator Cummins.
Mr. President, I beg to move that the minutes of our meeting held on Wednesday, the 17th of June, 2026 be deferred at this time.
The question is that the minutes of our meeting held on Wednesday, June 17th, 2026 be deferred. Will those honourable senators in favour please say aye. Aye. Those against please say no. The things the ayes have it, those minutes are accordingly deferred. But with further announcements, I have indications of absence from Senator Walcott and Senator Maladou, as well as Senator Niles. With further announcements, it's my pleasure to welcome and acknowledge the number of visitors with us this morning, headed by Dr. Margaret O'Shea, nephrologist and surgeon of the QEH, and they're here because of the item that should be on our agenda today, the transplant bill. Also, are members of the Barbados Kidney Association, including the president, Sadie Ann Sisnet. They also have advised a number of patients who've been transplant recipients as well as donors. We have as well, I understand, members or representative of the Law Reform Commission, which was one, in addition to the Ministry of Health and Attorney General's Chambers, one of the entities that undertook considerable work and consultation in getting this landmark bit of legislation right. We want to welcome all of you individually and collectively, and I trust that you will find your presence in the Senate today useful. And you can free any day to join us on YouTube. You can see us do our business, even when we're not doing things as exciting and as novel as this legislation. We're very, very happy to have you with us today.
Presentation of petitions, presentation of papers.
Senator Cummings.
Mr. President, I'm commanded to lay the following documents: the ILO Convention 193, Decent Work in the Platform Economy Convention 2026, and the annual report and audited financial statements of Caves of Barbados Limited, CBL, for the year ended March 31st, 2025.
Reports from select committees. Questions to ministers. Requests for leave to move the adjournment of the Senate on matters of urgent public importance. Statements by ministers or parliamentary secretaries. Personal explanations. Motions related to sitting or business of the Senate and moved by a minister.
Senator Cummings.
Mr. President, I beg to move the suspension of Standing Orders 45-2 for the remainder of today's sitting.
The question is that Standing Order 45-2 be suspended for the remainder of today's sitting. Will those honourable senators in favour, please say aye. Those against, please say no. The things ayes have it. That standing order is therefore accordingly suspended for the remainder of today's sitting.
Introduction of bills.
Senator Cummings.
Mr. President, I need to give notice in the first instance and then move the first reading of the following bills. So give notice of the Human Transplant Bill 2026, the Protection of Depositors Bill,
State acquisition.
of, no.
Acquisition, just the acquisition.
Okay. And then also to give notice of the State Acquisition and Vesting of Property Number 2 Bill 2026, and to move the first reading of the Human Transplant Bill 2026 and the first reading of the Protection of Depositors Bill 2026.
The question is that the Protection of Depositors Bill 2026 and the State Acquisition and Vesting of Property Number 2 Bill 2026 be read a first time. Will those honourable senators in favour please say aye? Yes, in fact, I should add to that the Human Transplant Bill 2026 and not seeing depositors. Yeah, already. Yeah. The question is that those bills be read the first time. Will the honourable senators in favour please say aye? Aye. Those against please say no. The things the ayes have it, those bills are accordingly read a first time. Public business is now the order of the day.
Order number 2, sir, in the name of the leader of the Senate and Minister of Health, to move the second reading of the Human Tissue Transplant Bill 2026.
Send to the Honourable Lisa Cummings.
Thank you very much, Mr. President. And I want to start, first of all, by acknowledging the incredible people who are here in this room. The Barbados Kidney Association has turned out in their numbers. The members of the executive of the BKA, you are here. Family members, supporters, persons who have benefited from the work that is being done by the BKA, all of you are here. the Queen Elizabeth Hospital. You mentioned before Dr. Margaret O'Shea, who has been extraordinary in pushing and advocating for us to be here, along with all of the stakeholders in this room on a day like today. And I really want to just acknowledge the incredible contribution that collectively and individually they have made. In an environment, Mr. President, where we talk all the time about giving back, advocacy, people being involved, people playing a role and taking responsibility for the things that happen in their lives, the work of the Kidney Association and the persons who are in this room today has been tireless. Without any additional remuneration, without asking, what am I getting? Am I getting a payment? Am I getting a stipend? Am I getting a contribution? Without asking for a single thing, they have stood up over many years and have advocated on behalf of patients and their families in this country. And I want, without any hesitation at all, to acknowledge not just their contribution to this particular cause, but to celebrate them as a model for service, because that's what you have provided. The second thing that I want to say is about the work being done by the doctors in this country. Now, we saw a few days ago, maybe a few weeks ago, the instance where there was a landmark procedure being done at the Queen Elizabeth Hospital, and we saw the celebration around that being as innovative as it was for Barbados and what it meant for the region. You know, we live in a society where a lot of times it's easier to talk about all the things that are not right. It's easy to talk about the things that are not going well. It's easy to beat upon the Queen Elizabeth Hospital and all the doctors that are there, and sometimes it's important to do that, but I am not an organ transplant specialist, Dr. Margaret O'Shea, who is here. She is. And the work that persons like her and others have done in this hospital that we choose oftentimes not to see is demonstrated by the number of persons who stood in this chamber today to say this hospital and these doctors have served us well. Even in instances where it's not always great, it's not always flowers and roses, but that ain't life. Let's be real, that's not life. Things will not always go according to plan, but I want to celebrate them. And I have to start, I could not get into the weeds of this bill without talking about what they have done here. They have worked not just here locally, they've worked regionally. They've been partnering with international bodies to be able to see how we can get Barbados to a space where today could be possible. And it is my absolute privilege to stand in this chamber today and be able to deliver this on their behalf, on your behalf, on behalf of all the family members, all the friends, but I also want to acknowledge those who we have lost along the way. Those who are not here to see today happen. Those who didn't get the benefit of dialysis support in the number of treatments that were needed, those that weren't diagnosed in time, those that didn't get a live donor transplant in time, and they're not here today, and I have to also acknowledge that their journey is a part of why we're here today, and also a part of why this work is so important. So when we look at this legislation, and we go through the various sections of the legislation, if I was looking at this and I was on the outside of this discussion and I was saying, so what's this all about? It's words, it's clauses, it's parts, but contained within each of the sections of this legislation, all 38 clauses of this draft bill, they're people's faces that are behind them. Family members who are thinking about those who they wish could have had the benefit of this legislation in a previous life in Barbados. And then there are those who are here and are waiting still. I know, excuse me, that on the 14th of July, we will have in our hospital, in the Queen Elizabeth Hospital, the next transplant. Dr. O'Shea and the other doctors who have been working on this stuff will be there, as they have been there for everyone else all these years. So I'm not here today to practice one-upmanship. I'm not here for gotcha moments. That's simplistic stuff. That's easy stuff. But the real work is in acknowledging the complexity of something like this and what it means for people. And I want to start there with this bill. So having said that, all that I've said, this bill is not really just about transplant. It is really the next phase in a milestone for what healthcare is doing in this country. I did not by accident talk about the innovations in cancer awareness that we saw in the newspaper last week. Recently, through this chamber and in the other place, we saw the Medical Products Regulatory Authority Bill pass this chamber. We talked about what we're building as an ecosystem for medical products and the regulatory framework. In the context of that, I talked about the Barbados Living Laboratory, and I talked about the Barbados Pharmaceutical Inc. All of these things, when combined, constitute the overall reform of a healthcare system that has, in many instances, outlived its sell-by date. And so we need to be able to innovate into the system, and we need to be able to put new structures, new systems, new processes into an antiquated system that meet people's needs where they are in 2026. But we're not fashioning it for 2026. We're fashioning it for the generations that are going to come behind while meeting the needs of those who are with us now. So overall, we've been talking also about drugs and what needs to be done. And I talked about the fact that in the pharmacy in the Queen Elizabeth Hospital, some of the things that need to be done there. I don't want today to be their moment, though. Today belongs only to the people who came here today from their daily lives and who have given up so much to be able to get us here. So this is the distinction that I want us to bear in mind here. In other discussions, we talked about the non-communicable disease crisis, and there are some who sit around this table who have had extensive experience talking about NCDs, and they're shaking their heads at me, Mr. President, so I'm going to ask you for protection from them, although I don't really need it, but just in case. Just in case. Where does this particular bill sit in the overall ecosystem that we've been talking about? Now, one of the reasons why this bill is here, and one of the reasons why we have been seeing the increasing incidents, and a few weeks ago I had a meeting with all of the various associations that are involved in advocacy, and there are quite a few. So from the Barbados Cancer Society, the Barbados Healthy Caribbean Team, the NCD Alliance, all of them, along with the BKA and their executive, we met in my office, and we talked about a range of things, including the NCD's crisis. Why are we having these issues with NCDs? Why are we having these kinds of debates today? Let's talk about this for a moment. We as a ministry have been talking about wellness, healthier lifestyles, choices about what we eat, prevention, screening, early diagnosis, and the importance of our primary healthcare system. We've been talking about the management of chronic disease and the importance of specialist care, like the nephrologist. And in the context of that, my first point that I want to make is the importance of screening and prevention. I want to start there for a reason. Poorly managed diabetes oftentimes translates into problems later. Poorly managed or even undiagnosed hypertension creates problems that will evolve later. And so we want to be able to make sure that before we get to the question of transplants, before we start talking about things like dialysis, that we start talking about screening and prevention. Where are we meant to start? I've lost track, Mr. President, of the number of people who have come to me and to others who work in the Ministry of Health and who've talked about the fact that on a random day, they just discovered that they had hypertension. On a random day, they just discovered that their HbA1c was elevated and it needed to be taken up. We talk about all the time the number of Barbadians who are either overweight or obese, Overweight meaning that for your body or your height, you're too heavy. Obese, different. We're having these conversations. What do you choose to put on your plate? Those are some of the things that are important in screening. And so when we talk about hypertension and diabetes and obesity and overweight, they're not really separate diseases. They culminate ultimately in illnesses that we want to avoid. They culminate in things like heart disease, stroke, and kidney disease. And we talk about the implications for the kidneys, the hearts, and nerves, and so on. Obesity, which we've been talking about, increases the risk of developing diabetes and hypertension. And when those conditions remain undetected in the first instance or poorly controlled over many years, the consequences become increasingly severe. Some patients are predisposed genetically to having a kidney disease, to having issues. And so they come and their family history and so on leads them to having some of these challenges. But for so many others in our country, we want to be able to find them before their illnesses become severe. So we start first with screening. Do you know what your kidney function tests tell you? Are you going to your primary care doctor on an annual basis for your routine checks? Every year in January, faithfully to coincide with my birthday, I go and I get my annuals done, my physicals, every year, January. Sometimes in this life, in this job, since I've joined Cabinet, I haven't always had the time in January, but no later than March, in every given year, I will go to the doctor and I will have my screenings done. I will get my blood work done to see what's there because I want to know early. I will get my breast screenings done and all that kind of stuff done, all at the time of my birthday. But how many Barbadians have what someone described to me today as the fear of knowing disease? They don't want to go and get screened. They don't want to know, but what if I find something? What do I do? What happens then? So they don't go. And then that becomes problematic because a little later on, you don't know. And when you don't know, it remains undetected and it can't be treated early. Someone mentioned to me yesterday in a meeting that we had that they encountered someone who they encountered for the first time at stage 5 kidney failure. And they had no way of helping them. We want to be able to launch a program that helps people to find their way before it gets too late. So the question for us as policymakers and advocates is, can we change the circumstances around not knowing disease, not wanting to know disease? Can we get people to do their annual screenings? I think that we can. I think that we must. And so the evidence that we have seen in the Ministry of Health and from all the advocates point us in one single direction. It tells us that first and foremost, we have to be able to have a national screening program. I'll come to that in a little bit. Let me be clear, this is not a criticism of patients. This is not a criticism of our healthcare professionals either. And it's not a criticism of the overall system, but it is a recognition that healthcare is changing and people sometimes are afraid or mistrustful of what they are going to find when they go into a doctor's office. So we want different outcomes. If we want different outcomes tomorrow, it needs us to intervene today. And we want to be able to make sure that by the time someone is talking about a transplant, that they have had the benefit of all the services that have come before it. First with screening, access to dialysis, and I'll talk about that in a little bit. So we are focusing first and foremost on prevention and on screening as perhaps the most important tool that any health system can make, and that's where the primary healthcare system comes in. Then the second part of it is on dialysis, and I talked a little bit about the dialysis support. At the Queen Elizabeth Hospital now, we have somewhere around over 240, I think is the number, of patients, 340, somewhere thereabouts, on dialysis. And they're there in a 24-chair facility, not bed in this instance, in a 24-chair facility at the QEH. And then we also have smaller facilities in partnership with a private sector provider at 3 different locations. One location in Belleville, one in the St. John Polyclinic in St. John, servicing that part of the country. And then we have another facility in the Maria Holder Trust building in Warrens where you go, obviously because of the connection, as I made it before, between diabetes, uncontrolled diabetes, and kidney disease. So that is happening there as well. 3 locations. But we're now looking to do more. There are people who are having 2 treatments of dialysis when they should be having 3, simply because the wait time and the capacity is growing faster than the facilities are providing the support. We need to be able to meet people's needs where they are. When I talk about 300 and some odd persons, and I talk about 3 different locations across the country, that seems a little bit esoteric. It's bricks, it's mortar, it's chairs, it's medication, and so on, but there are people in the system who need those services. When I went to St. John Polyclinic and I toured the facility there, and I want to acknowledge the work of Barbadian entrepreneur based in Zurich, Switzerland, Mr. Kurt Lambert, if with permission I can call his name, he's been featured in the newspaper multiple times, who has no reason to give of his time in the way that he has, except for the fact, and he's shared of it publicly, so I can say this here, he had a mother who went through this. He lived kidney disease with his mom. And so he was vested from his personal experience to be able to give back to others, so other people will be able to have the benefit of his capability. And so Sills was born. We had the facility in Carrington Village, and it's in Carrington Village still. They do a lot of the screening. They do a lot of the initial work on prevention. And Carrington Village, you ask why in Carrington Village? Because that's where he was born and raised. That's where he was from. And so in a tribute and a nod to his mother from her walk, her journey with kidney disease, he set up in Carrington Village first. And there are people who walk into that facility every day and get screened and then are able to be shuttled throughout the system. But the morning that I went to St. John, I think it was an afternoon actually, I went to the St. John Polyclinic, St. John, and I saw the Sills facility there. There was a young lady who was there, and she was there with her brother. Again, family members and family support is important, right? This is not about somebody else who has to do something for us. It is the importance of family relationships and family support. She was there with her brother, and she said to me, he lives a normal life, he has a job, he goes to work on a day-to-day basis, but they go into the facility at 4 o'clock in the morning. They dialyze, go back home, get ready for work, and go off to live their life. So imagine you also have the persons who are at that facility, who are there, they get to work on mornings to be able to open the facility for 4 o'clock in the morning. They're also to be commended. And that's so that people can be integrated into day-to-day life because they have support systems that are working for them. So they go in. So St. John Polyclinic has that. Then we talk about where the QEH is. The QEH has a facility presently, as I mentioned before, with 24 beds. But is that the ideal location for what we do there? Is that the best case scenario? One of the things that we have agreed as a ministry is to expand the capacity for care and to ensure that no person who needs dialysis is without access to care. And what that means is that there is the intention when we're able to expand, we've already talked about expanding the Queen Elizabeth Hospital, we've talked about renovating and building the polyclinics in different locations, but equally so, what that means is that in these locations across the country, because when we started talking about it, we understood that just like that young lady and her brother in St. John, people want to be able to be close to where they're coming from. Having facilities in communities will matter to people so that they can continue to live their day-to-day lives. Imagine if I lived in St. John or in St. Joseph and I had to leave and come down to Bridgetown, only to Martindale's Road to get dialyzed and then have to go back to my life. That's a little bit difficult and it makes it even more challenging for people. So you'll hear me use that word all the way through. People, this is what this is about, people. People who need our support. So, in different locations across the country, we will continue to support that, but it is our intention to expand significantly the capacity in a central location to give persons additional access to dialysis support. If it is 2 treatments that you need a week as a and it's not 3 and you need 3, then we want people to be able to have 3, because from what I've seen and heard from the doctors and the professionals, that improves outcomes. So we want to be able to give that additional support. Then we talk about where we need to go to support the persons who, after they have screened. When persons have been screened, they've already gone through the dialysis support, where do they go? We want to be able, and I said that I was going to come back to this. Over the last couple of weeks, as I've continued to delve into the weeds and the systems of the Ministry of Health and Wellness, we started to have a discussion. Yeah, we talk about screening. When it's your 50th birthday, as it was mine in January, Mr. President, you have people who are having these celebrations, right? They say, oh, yeah, when you turn 60, you have a, what's it, a diamond or jubilee? I don't know what it is. 70, 80, like Dr. Connell, somewhere up in there. You want to be able to have these various celebrations. That's what people do. So as a Ministry of Health, it is our commitment to be able to pair the celebrations of people's milestone birthdays with a national screening framework. And what do I mean by that? The program is meant to be anchored by what we call a life course screening framework, and it begins at 20. Why is that? When I was 20 years old, I never used to read nutrition labels. It tasted good, I want that. I was not socialized to read nutrition labels. I don't know what in it. If it tastes salty, yummy. If it tastes sweet, not so much. Then I'm more salt than I am sugar. But I'm going to make my decisions on what I like. But we have to start socializing our people differently. We have to start talking our people through what they need to do now in order to make lifestyle changes later. So we propose to start it at 20. When you get 20 years old, or maybe 21 as an odd number, that becomes the specific milestone that people tend to celebrate. When you hit 2021, what should you be doing as part of your life course screening? Give you an early indication, and I'll give you an example. When I had my daughter was born at 26, when I was 26, I had my daughter said, my aunt said to me, she said, you know, Lisa, we have a history of diabetes in our family. So watch your weight, manage what you eat, control your sugar consumption, your salt content, and so on. My daughter is now 26 years old, the same age I was when I had her. And I have not used sugar actively since my aunt told me that at 26 years old when I had my daughter. I don't add sugar to my tea, my coffee. I don't have a sweet tooth. I'm not having a dessert, none of those things. Because my aunt said to me what my family history is. She told me, I was just 26. Salt, I'm not a big salt eater, but guess what happened to me? Guess what happened to me? And I told my staff this story. One year, for those routine annual checks, I went to the doctor. And my HbA1c levels came back, and they were higher than they should have been. And the doctor says to me, but you know, Lisa, at some point, you eat well, you don't eat junk, you manage what you eat. You may not exercise as much as you probably should. Okay, let's work on that. But at some point, your genetics cannot be outrun. But I knew that because my aunt had said that when my daughter was born. So 20, let's start telling our young people what is their genetic predisposition, what's in their family history. So we started at 20 for that reason. Then you hit 30. What happens at 30? By this time now you have a baseline at 20. Let's hit 30. In the 10 years, the intervening years between 20 and 30, what has happened to you? Are you seeing your numbers shifting? What is happening in your lifestyle? What decisions are you taking? What are you exposed to? Then by 40, by 50, we talk about things like all the various things, breast screening, prostate screening for men, colon screening by the time you hit a certain age. Let's normalize these things at milestones, and that's what the life course screening framework of the Ministry of Health is being developed to do, to normalize screening, because it's important for us to get detection and prevention so we can get in front of these illnesses. We're building a new wing to the Queen Elizabeth Hospital, Mr. President. we extend into Queen Elizabeth Hospital. But if we do our job well, if we do our job in primary health care well, our job really has to be to keep people out of it. As far as is possible, in areas that they can control, to keep people out of that hospital, and to make sure that we can manage by first finding, detecting, and treating things that can be avoidable, because we know we have an NCD burden. So 20 is not too young to begin thinking about it, and by the time you hit 70 and 80, then you have had from your 20s all the way through a life course screening, and you know your body better than most. So now you know what you're meant to do, what you're predisposed to, and what changes are required of you. So that's the first thing, because lifestyle habits become established long before disease is diagnosed. So we need to focus on lifestyle, and that's the reason why we're focusing there. Then I want to bring our attention to the actual bill itself, because we have an aging society. Just yesterday, I saw a story. I don't even know where I saw it. I saw a story. It talked about the blue, what do you call it? The blue zones? Is that blue zones? Blue zones. And they said Barbados is second in line globally as a blue zone, because we have all these people who live really long, 100. I saw one in the newspaper today. And so we have all these people. But guess what, Mr. President? We're debating today a human transplant bill. If we have a high NCD burden, people are sicker, people are living with illnesses or undiagnosed illnesses or poorly managed illnesses, a donor program in a country that you have people living longer but not necessarily living healthily creates strain on the system. So even though you may have a family member who is willing to be a live donor, that family member may not be well enough to donate that organ to their family member because they are living with an undiagnosed or poorly managed NCD. So you go, you have a heart disease, you have hypertension, and you don't know. You have diabetes, and you don't know. How do you manage these things to make sure that you yourself are healthy? But when we talk about blue zones, just not living long, but living well and living healthy. So this is important, because living donors, family members and loved ones who want to be able to donate, need to be living well, need to be living healthy. And that's one of the things that we're talking about at this point. So these diseases are critical for us. So I want to get into the legislation itself now. In the legislation, why is the legislation then necessary? Because we have had, and we've always done, live donor transplants. That's always been done. I talked about the one being done on the 14th of July this month. But the legislation then talks about what the challenge is, what challenge is being presented to us. Under Part 2 of the legislation, it talks about the approval of a health service institution, the establishment of the council and what the functions are, and designated transplant officers. And if you go through the transplant officers, it's captured in greater detail in the schedule appended to the bill. So what is the council? What is it meant to do? It's meant to be able to evaluate in an objective and an independent manner the circumstances surrounding transplants. It is meant to be in a position to guide the hospital on how these things are meant to be done in full respect of patients and their families and established medical procedures. I'll come to that in a bit. In Part 3 of the bill, it talks about National Donor and Transplantation Registry. First, the establishment of the registry. Now, the Ministry of Health and Wellness already maintains a registry in partnership with the University of the West Indies for a range of other things. The intention is that as part of that overall body of work, that the work specific to transplants will be embedded within that as a dedicated module so that we have access to data, and the Ministry of Health provides the financial support to the University of the West Indies to maintain that registry. And the intention is, rather than to create something, again, brand new on a parallel track, to simply build on what we already have in registry support and to specifically support the National Donor and Transplant Registry. Public education. I can't stress how important this is, because there are people who I have heard anecdotally banding around things like this that have made this bill into something that it is not. They've minimized the work of the people in this room by attempting to make this bill something that it's not. They've attempted to have that gotcha moment because they want to minimize what has been done by the people here. They want to have a 30-second minutes of fame, and so they're going to come with all kinds of ahas. But what about this? But what about that? I hear this, I hear that. But it may not be rooted in fact. So public education is going to be critical. What happens when I see a bracelet on somebody's hand that says, I want to opt in to have my organs donated if I pass? What happens then? That's done all over the world. In so many countries we've seen it. We know what the bracelet looks like. This legislation allows patients, persons, nationals, Barbadians, anybody to indicate that they want, upon their passing, to be able to donate their organs. I intend to get one of those bracelets. I intend to be able to say to my relatives that when I pass, I want my organs, God willing they're healthy, to be donated to someone who needs them. I don't need the ants to get them. I don't need them to go back to dust. I need to be able to give the gift of life to someone else who needs it. That's what I want. But that's just me. Everyone may not feel the same way. So there may be people who are afraid. In the same way that there are people who don't want to know, afraid to know disease, there are people who want to take their body right back to the grave just as they came. And we need to be able to share with people what that education process is designed to do, how it can be done, how it's being done safely, and more importantly, how to honor the family members of those who have passed. Because I am certain that when I'm not here anymore, my family members will mourn me. My family members are going to say, I wish she was still here. The people who love me, people who are close to me, are going to mourn my passing. And we have to honor the fact that it's a difficult time for family members when they lose a loved one. But I also, because it's my choice, I also want my family to be able to meet, as I've seen in other countries, someone who has been given the gift of life by the person who they loved. To meet that person who has my heart. Not my heart personally, but my physical heart. To meet that person who has my liver, that person who has my kidney, that person who is able to hold their newborn baby because I have given the gift of life. I want that. And I would love to be able to see how, through our public education program, we can inspire even more people to give the gift of life to another family and to give persons an opportunity to live life as fully as we have in many instances. The donation of tissue by adults, this is an important section of the legislation because one part of it that I want to speak about is the effect of consent. This is all consensual. I've talked about what I want to do and what instructions I will give to my family, but for live tissue, for persons who are donating their tissue, live, donor, or otherwise, then we want to make sure that they have the ability to give consent, and this legislation frames that. It didn't exist in this way before. It's now in a single place. Now, in Part 5, donation of tissue by minors. Minors, last we knew, in this country could not consent to anything. But there is a framework captured in this legislation that outlines the conditions under which a minor can be involved in Section 17, what is the effect of consent, withdrawal of consent, and what happens in those circumstances. It's well framed out, well articulated. Paired tissue donation, that's another part of it. Donation of tissue after death, I think I've just spoken about that as well, but it also attempts to honor those who have passed. Removal of tissue after death, conditions under which this may be an exercise authority by the transplant authority, and when death occurs, concurrence of the coroner. In all instances in this country, when a person passes, you will have the coroner's report as to the cause of death. If someone dies in an accident, if someone dies in something else, you have the passing. If you have not given consent, in some countries, automatically when you pass, your organs are donated. There are countries like Switzerland, automatically, bodies will go and the organs are taken and they're donated to whoever's next. That is not what this legislation does. It does not do that. People have the right in this legislation to choose if they want to donate their tissue after death. There's a section here which speaks to the international requirements that Barbados is going to be signing on for and committing to, which is in Part 8, which is the prohibition on trading in human tissue. That speaks for itself, and so we have that in the legislation, and then we move on from there. But I've gone through the legislation, I've talked about screening, I've talked about prevention, I've talked about dialysis, and I want now to come to another component of this, Mr. President. I want to talk about what comes after the legislation has passed. By the time we finish passing this legislation, what comes next? What is required of us? Because good legislation is really not just the end of the conversation. It's good legislation. This legislation has had the benefit of the input of the people in this room and others. I want to acknowledge the work of Sir David Simmons and the members of the Law Reform Commission who have also been actively involved with all of the stakeholders in developing this body of work and considering the World Health Organization regulations, what the international legislative framework has evolved into, what other jurisdictions have in place, what's missing, what can be done, what this legislation could look like. And that long journey has led us here with the benefit of all of those people. On Sunday afternoon, I had the opportunity to spend some time talking to Sir David about the legislation, and I have the benefit of them assessing the legislation before us, what they recommended, what has since been included, because they made a number of recommendations in collaboration with the stakeholders and submitted those recommendations to the ministry, who then worked in turn with the Chief Parliamentary Counsel's office to integrate many of the comments, and that is what you have before us. This is a long, consultative, and extensively engaged process that is culminating here today. And the people who have been involved in it are some of the most recognized luminaries in their respective fields, not just locally, but globally, and I want to acknowledge their inputs. So the implementation now is where we have to come. I've already spoken about public education and the need for continued learning. What happens next, though? Because legislation alone is not going to perform the transplants. Legislation alone is not going to train our surgeons. Legislation alone is not going to educate the public, neither is it going to strengthen our laboratories. Legislation simply creates the framework. It creates the foundation. That's what we have here today. The real work begins once the legislation has passed both houses to actually operationalize it. And that's where I am most excited. So passing this bill, I hope, which we can do today, is an important milestone. But we have to be able now to work on what comes next. So for me, the answers are finally straightforward. We have to continue the conversation nationally and publicly. We have to continue building on the continuum from screening and prevention, treatment and transplant that we have talked about in this debate so far. We have to continue investing in healthier lifestyles and strengthening prevention. We have to expand the screening in the ways that I have described, but then there are some specific things that we also need to do. We have to strengthen our specialist services. We need more of the specialists who are functioning in this space to be able to ensure that we can have treatment capability. We need to be able to make sure we have a national transplantation system. There has been discussion, and I've committed to the team here that in September, God willing, when the Council on Health and Social Development of CARICOM meets in Guyana, that one of the things that I intend to do is to place this matter on the agenda. In March, I think I was appointed as Minister of Health in February. In March, we had the first COSOD meeting. And I took the opportunity then to place an item for Barbados on the agenda. That agenda item at the time was each country in the Caribbean collaborating on the things that were points of strength for us in health. So if Guyana is doing one thing, how do we build on the work that Guyana is doing? They're doing incredible work in genetic sequencing and what is predisposed for bodies of our type as distinct from those of a different type. And they're doing incredible work. Barbados is building, and I presented at the time on the pharmaceutical work that Barbados was doing. But it is my intention in September to place on the agenda collaboration for a regional donor bank for organs so that we have access to not just a small pool that is Barbados, but whether that organ is coming from Trinidad or from St. Kitts or from Guyana, that we have a framework that allows us to collaborate intra-regionally across the millions of people across the region so that we are able to help more people. So that's one of the things that is on my to-do list operationally after we have this legislation passed. We also want to be able to build public confidence. Families need to be able to ask questions about their relatives and their loved ones. We need to be able to make sure that through the system, when your relative comes into the system and they're on the inside of the treatment room, who is answering questions for them? Who is the focal point for them? Because I always say to my team in the Ministry of Health, you're not meeting people in the hospitals on their best days. You're meeting them, chances are, on their worst days. You're meeting them when they're feeling the most vulnerable, either vulnerable personally or vulnerable because their loved one, their family member, their close friend is having a bad day and they're there with them. So we need to be able to do some education at all levels across the system that allow for us to have a person who becomes your focal point for every step of the journey. You know, like, and I think what inspired it was it Alcoholics Anonymous, where you have, who's your sponsor? Who's your sponsor? Do you have someone to take you through your journey in the system? It's my commitment that every person who enters our institutions should have a sponsor of some kind who's able to walk them through and be there for them, sometimes in their lowest, but to celebrate with them when they're able to see the recovery and they're good and doing better again. We need to be able, we discussed this yesterday, for every skilled surgeon that we train, we need to have the number of nurses trained to go along with them. The doctors told me this week, and the nurses told me this week, I met with all the nursing administrators, they said to me that for every specialist doctor, we need 4 trained nurses. But let's be clear, right? I don't do superficial stuff. So I don't have, again, a gotcha moment. I can tell you now from an assessment of the system as a whole, what we have. And I can tell you that in many instances, let's start with the output. We're producing, on average, 24, 25 nurses out of the Barbados Community College School of Nursing every year. No more than 25. The total capacity is 70. So we don't have the intake in the first place to be able to produce what we have capacity for. One year, we produced 100 nurses. That year, we talked about the failure rate being high. But why was the failure rate being high? Because when classroom sizes are too large for the capacity, you're going to have higher failure rates. You're going to have all kinds of issues. So we figured out what the input challenges are. But all the way through the system, we still have challenges. I'm not going to go into them here today because this is not a day for nurses. I'm not taking the moment away from the people who are here in this room. But we need to be able to train nurses to go along the journey with specialist surgeons and nephrologists who are able to have the specialized care. And there are incredible people in the AKU, in the Queen Elizabeth Hospital, who serve every day as nurses supporting patients who are there. We need more of them. We need the laboratory scientists, people who are able to do the testing of the tissue so that we are able to have instant testing. A few weeks ago, we opened, Prime Minister led the redesignation or the designation of the Best Dos Santos lab as a WHO center for antimicrobial resistance. And they are actively working on other things, including being able to produce real-time testing of tissue for the purpose of matching donors to patient recipients. That's something that they're actively working on now. That also benefits us in the support program for persons who are benefiting from kidney transplants. Laboratory scientists, yes. Pharmacists, making sure that there's necessary medication counselors, social workers, transplant coordinators, rehabilitation professionals. All of these things go as part of a multidisciplinary team that must work together. So we're not just training the surgeons because that's what's front and that's what's visible. So that's what people see first. We had to train the throughput and all of the multidisciplinary professionals that are necessary to be there. We need to be able also to strengthen the scientific infrastructure that supports transplants. What is that? Technology is evolving at a rate now that there's new equipment, there's new technology, there are new procedures. We need to be able to make sure that beyond surgical expertise, which clearly we have, but we also are able then to build the overall capacity. Tissue typing, immunogenetics, histocompatibility testing, quality assurance, clinical data, and overall research. These are not, for us, separate conversations. They're part of the whole. And so we want to be able to make sure that we strengthen Barbados' capacity. The Barbados Living Lab has already been created. It's there. That's the foundation. We're now building on that. Information systems, same way. We need to have the registries, which we spoke about. We need to ensure we have secure clinical information, reliable patient data, and systems that support quality, transparency, and continuity of care. We need partnership. That's the other part of it, partnership. And I mentioned before SILS and the extraordinary work that they're doing with Barbadian investor who has a personal story that has motivated him, his mom. And so partnership with SILS, partnership with all of the other partners that are already doing work with us out of Trinidad and other places who are collaborating with our transplant team. I'm told that when the next transplant takes place on the 14th of July, that we will have the benefit of a partner coming from overseas, I believe as close as Trinidad, who will be here to perform the surgery along with our own surgeons. So partnerships matter. It requires not just the Queen Elizabeth Hospital. It requires the various locations that provide primary care, screening, and day-to-day treatment, like our polyclinics. It requires the University of the West Indies. It requires our healthcare professionals. It requires our professional associations. It requires patient organizations. It requires civil society. It requires regional partners. It requires international partners. It requires us. All of us working towards a common goal in support of the people who need it most. It is for that reason that my ministry has undertaken to begin the work on a national organ donation and transplantation strategy so that we have all of these diverse pieces together into a coherent, supportive framework that helps to empower those who are doing the incredible work to continue knowing that they have the benefit of the state's support, even whether you are civil society, private sector, advocacy group, patient groups, that you know here's where you go for what, and that the government is behind you 100%. Certainly this government is 100%. This is a reform initiative. It is a foundation response initiative. It is appropriate, it is timely, it is planning. And I want, Mr. President, to say to you that after all these discussions, after screening, after detection, before prevention, setting milestones, a screening framework, after treatment, after transplantation, and after legislation, this debate ultimately comes down to a single question. What kind of overall health system are we trying to build for Barbadians? Today, it's transplants. We have the benefit of the various organs that will have the output of our work today. We've heard from medical products already. We talked about living lab. I'm talking about pharmacies. So piece by piece, bit by bit, incrementally by incrementally, we are building a healthcare system that by magic isn't going to appear overnight. It's not going to just pop up tomorrow and be perfected after years and years of systemic challenges. But together, piece by piece and all together, we are building a healthcare sector that benefits our current generations, but is being built for future generations. And it is built on the shoulders of the people in this room. Not in this instance the ones around this table, but the ones around the chamber who have stood up and said, here I am, use me, who have stood up and unwaveringly and with absolutely unflinching commitment stood up and said, this is a cause to which I am committed, it is important, it matters, these are real people, I am here, and I'm standing in the gap for someone who needs me to do this. And so today is your day. This initiative is your initiative. This legislation is your legislation, and this is your example for all of the other associations and patient organizations and clinicians who are doing incredible work, that these pieces all will come together to build a healthcare sector of which all of us can be proud. And I want to commend you, I want to thank you, I stand with you, and with these few words, Mr. President, I beg to move that this bill is read a second time.
Thank you very much, Senator Cummings. I'll ask the Deputy President to take the chair for a while.
Senator Goodrich. Thank you, Madam President, Madam Deputy President. Good morning to all today. It is a pleasure and an honor of mine to be discussing this human tissue transplant bill of 2026. And Madam President, this bill is one that I can say outright that I 100% support. Yes? And of course, you know, if it was at 99% for anything, it would be in scrutinizing the legislation and recognizing anything that should be fixed before it is passed. That is still my job, and I enjoy it. So I want to acknowledge the presence of the members from the Law Reform Commission and from the Barbados Kidney Association. And I also want to acknowledge those members who are advocating for this bill to come today, who are involved in the QEH transplant program. Now, a bill such as this is important to me too, ma'am, because I have friends who have been through dialysis, who have sat for hours at the QEH. I know the pains, I know the frustrations, I know that they have to go 3 times a week, sometimes 4. I know that sometimes based on the situation at the hospital, they only may get to go 2 times. And I also know that there are other members outside of the friendship that I have with people who definitely have been advocating for this bill to be passed, because this bill is one that has affected them economically and academically in their personal lives. And I say that because if you are a student at the university or at any other school in Barbados, and you have to be a person then that is going for dialysis because of some type of kidney issue. You miss your classes as a student, and then you have to fill back in time, and then you're behind in your studies. Even individuals who are employed, you may own your own business, and if you own your own business and you have to take out the time to go for dialysis, that is your money being affected. That is your family, by extension, that would be affected. Because you could be a breadwinner in a family, and you being a breadwinner in a family and having to provide for your family, and then you recognize that your pay may be lower because of the time that you might have to take from work. I don't know their employment situation, but I understand that it would be affected. Even if they have to go to the hospital and they have to wait there for hours, by the time you go in there and you have to come out of the hospital, you already are feeling tired, great fatigue. And I also know of the scarring issue because, of course, you're going to have to go through surgical procedures. You're going to be injected in order to receive the dialysis. And then you have a scar somewhere about your body, right? And all of that affects people emotionally. And that is why there are members of our very society who wants this bill passed. I don't know if they believe that it is as timely as we may say, but I know they want it urgently. So the bill is a useful method to manage this transplanting of regenerative and non-regenerative tissue in Barbados. So I always want us to start at that human reality base behind the organ failure in this society. Because the human reality is the real driving force for the implementation of a bill of this nature. Now, the bill is about saving lives and helping people to have a better life in society. So persons who had to go through the delay process and just rely on family and loved ones. No, you can have deceased donors here taking part in such a modern movement. This legislation is a landmark piece. It is groundbreaking in itself, and it will continue to save lives once it is passed, I know. But of course, Madam President, you will always find legal issues, ethical issues, and medical issues occurring. So myself, as Senator, in my speech, I will allude to some of that. So I just wanted to let Barbadians know, first of all, I read the bill. It defines important terms such as the donor and the tissue and the transplants. So in the bill, you don't have to worry about the interpretation of some of those important words that will be used, such as next of kin. It explains those. It also gives room for, it provides for the appointment of transplant officers responsible for ensuring the lawful and ethical donation procedures. It also makes a valid consent sufficient authority to proceed with the transplantation. So you can see from reading the bill that it has the guardrails that are necessary to protect members of the society we live in and to protect those members of whom it concerns. So the legislation reflects an important reality that confronts the healthcare system. So this is a reality for Guyana, it is a reality for Jamaica, it is a reality for Trinidad, it is a reality in the Caribbean. So this is the reality here. And the point is that we acknowledge this reality from our brothers and our sisters in other islands who have surpassed us and passed this legislation. So now we too are falling in line to ensure that we understand the reality and then we put everything in place, every method that is necessary to ensure that these vulnerable persons in society can have the life that they so desire to live. So they can get back to normality. They can get back to feeling good. For the ones who are in relationships where sickness and so on causes issues, you can get back to your love life. And that is a reality. That is the reality that they are facing today. Those are things that we can't forget We have to zoom out sometimes out of all the legal terms and so on and really get back to the reality and the reality of those important people in society. So the human tissue transplant bill, it seeks to address the challenges that those persons face today. As I said, the bill starts with a clear legal foundation and the key concepts have been defined, and I appreciate that. It recognizes that the transplantation requires specialized oversight. The bill authorizes only approved health service institutions to perform the transplant procedures, and it establishes a National Transplant Council, and the council will oversee transplantation policy, advise the government, approve the designated transplant officers, and serve as the principal regulatory body responsible for maintaining ethical standards across the national transplant system today. So I do want to zoom in a little bit and say I know that there's cost for medication. I know the economic burden that it has placed on the country. I'm aware that it's the taxpayers' money that has to fund all of these, that has to fund the members of society who are affected with any medical issue today. So I know, Madam President, that if this bill is passed, there would be a plus in terms of removing, I would say, that tax burden of the people. Because as long as then you pass this bill, then persons will recognize that the high cost that is affecting the hospital now will come down. And I know that this is something that the specialists of the QAH transplant program did allude to. She talked about it, the cost that, QAH has been faced with and the country itself. And that is why we always have to gain public confidence in ensuring that when these bills are passed, we are truly reminding the public to have confidence in us as a parliamentarian member. Have confidence in us that we are looking out for the country and we are living in understanding the economic realities that will face our country. We understand the burden. I'm not saying that because someone is sick, it is a great burden upon us, but we understand that cost can be a burden on our country. And we want to limit costs as much as possible because sickness is something that will happen. Kidney failure is something that will happen. As the leader of government business mentioned, the non-communicable diseases, that is something that does happen. And we have to make sure that the public is educated in this area, because when the public doesn't understand, that is where you will see some people may oppose it because of religious or cultural beliefs. So public education is definitely important so that then those persons who may fall into that category of the minority would recognize the essentiality of this bill. Now, let me just take a moment here, because I took some time reading a lot of information from the World Health Organization. And I know that sometimes in life, issues always would occur. Because while you scrutinize a bill, you will always find the benefits, but you can always find the harms, and there's always room for making recommendations so that you could eliminate any harms that are possible and any issues that may come up and affect any member of our society. So some of the issues I recognize that come up a lot are disputes concerning consent. And I said before that the bill alludes to the consent factor to ensure that consent is given. I looked at the schedule, and one recommendation I would say is that in looking at the schedule, I recognize there are many forms. I find that the bill could have had a form, with the donor pretty much stating, I understand X, Y, Z, and what's not, and a form that will have their signature. That is a great recommendation. I see that is there from the designated officer, but I looked at Guyana's legislation, and I looked at Guyana's legislation, and their Form A was pretty different. So when you look at the schedule there from Guyana, and they have that Form A, it is quite different to ours. But I did recognize that this bill is similar to the one that is in Trinidad. So that will be just one of my recommendations. And one of the things that I want to pinpoint to is the aftermath. Proper record keeping for the hospitals. That is something that is key, it is essential. You must keep proper records, and I would say that keeping proper records will be for proof of valid consent. And I know that there are issues that could arise, legal issues too, where the consent forms may be missing. There are instances of that could arise. I've seen it in legal cases here in Barbados. And then people challenge the validity, yes, of that donation. They will say, oh, well, let's challenge validity here. Let's challenge the validity of that consent if a form is missing. So you need to prove that consent was valid, so we need to keep proper records on that. We need to protect citizens' rights. So accurate records safeguards the rights of the donors, the recipients, and the family members. Because sometimes family members, of the deceased donor may want to challenge it and say, no, that person didn't consent. So if you keep the proper records and you have that on file, don't lose it. I'm speaking to the persons in the institution. Keep those records proper and make sure that you do not lose them. Also, evidence in court. Keeping proper records will be used for valid evidence in court. If a dispute or criminal investigation arises, consent forms become important evidence. So missing, having incomplete or inaccurate records can weaken a legal case and expose healthcare providers or institutions to liability. Now I'm back speaking on issues that I've seen in the World Health Organization reports, and one of those issues are organ and tissue trafficking. It happens in other countries. I do pray that we don't have that issue here in Barbados, and that all goes well, because despite laws prohibiting the sale of human organs and tissues, illegal trafficking can occur in certain territories, and vulnerable individuals may be exploited. They may be coerced in certain circumstances. I'm not making up these facts. I'm saying these are things that happen in other islands that, of course, the bill is here to protect. And I'm not worried about that because I've read the clauses and I've recognized that the clauses has protections. Even where, say, for instance, there is perhaps lack of availability of some donation. We are making sure here in the country, right, that persons who are on the wait list, that those organs, those tissues are transplanted fairly. And I've seen that the bill covers that. Now, another issue, as I've just said, would be that factor concerning inequitable access to transplants. And the bill speaks to that. Because limited healthcare resources can result in unequal access to transplant services. And you don't want that these perceptions of unfair allocation could affect persons' confidence in the healthcare system at all. because they know we live in a time that if anything goes wrong in the healthcare system, you know what happens. People will be upset, they will be angry, and most of all, they will lose public confidence and trust in the healthcare system. And with a bill as such as this, we don't want them to lose public confidence, because we want that even persons who are living would feel more inclined to donate to those individuals who have kidney issues or kidney failure. We don't want then that any kind of issue would cause them to not even want to donate, because you need the donations. You need the donations, and we need all persons to support the movement in Barbados, because it is one that saves lives. It is one that causes them to have a better life in this country. Better Barbados is always what we are trying to achieve. Better Barbados. So I recognize too, I want to make this point, it's important, that the bill does prohibit the removal of the non-regenerative tissue from the living minors, and it permits certain donations by minors who understand the procedure with parental consent and medical safeguards, and that is commendable. And we recognize that minors are the vulnerable ones in the society, so the bill addresses that factor. Now, Madam President, if we are importing tissue, then we need to maintain a blacklist of nations from which we will not import tissue until it is objectively verified that they no longer engage in the offensive practice of forced harvesting of organs. Because I recognize from reading the bill under that section 36 that the minister may make regulations for the importation and the exportation of tissue. So that would be my recommendation, and I want to lay before the Senate the 2024 report by the Doctors Against Forced Organ Harvesting, and that is just for public knowledge, so that as you weigh the pros and the cons in addressing any issues that will come up with this bill, we will look at the doctors who spoke against forced organ harvesting. So, Madam President, there's not a lot more that I would say, honestly, because I really do support the bill. I support every individual who has been going through issues with dialysis. I support every person who needs a liver transplant, bone marrow. I support them, because putting myself in their shoes, I know it isn't a good feeling when you want to feel better and you're waiting on Parliament to just pass a legislation to help you to make your life better. So for me, as a young individual and understanding that, I support the bill. I thank you.
Thank you very much, Honourable Senator Dr. Connolly.
Thank you, Deputy President, Madam Deputy President. I rise to lend my voice to this debate on this bill, but first to acknowledge, as the Leader of Government Business has already done so, the presence of the Barbados Kidney Association, referred to as BKA. We know in medicine BKA has many meanings, but the Barbados Kidney Association, and also to salute my colleagues, all members of the association, but especially my colleagues, Dr. Margaret O'Shea, the transplant surgeon, and my classmate at the St. Augustine campus, Dr. Jurowan, nephrologist, who obviously are very much part of the CARE team. I also want to echo the minister's sentiment in her congratulating the transformative work that is occurring at the hospital. And she referenced the recent major surgery done in breast cancer by one of my colleagues, again at the University of the West Indies, Dr. Dale Springer, who is a breast surgeon. And perhaps, Madam President, this is a great opportunity for me to highlight, because in some jurisdictions, universities are seen as parasitic in the health space. The benefit of an academic institution and its partnership with a hospital. And I will use examples of, we have already mentioned Dr. Dale Springer and Dr. Margaret O'Shea, but I want to also share some data with you. Madam President, are you aware that the Eastern Caribbean Medical Scheme, for which the University of the West Indies was birthed in terms of medical care here, started in 1967? And that the Doctor of Medicine programs, which train specialists in Barbados for the people of Barbados, started, I believe, with the Family Medicine program in 1981. Since then, Madam President, Deputy President, there have been 194 graduates from the University of the West Indies DM programs in various specialties, internal medicine, myself included. Dr. O'Shea is a graduate of the general surgery program, and Dr. Gerland is, of course, a graduate of the UWI. Dr. Dale Springer did his Doctor of Medicine in surgery as well. What many people may not know, however, is that as they approach the hospital and with all the innovations and in healthcare that are occurring, many of the consultant staff there who are guiding medical teams and guiding medical care from the emergency room, or maybe let's start in primary care, from the primary care polyclinic setting right up to the transplant room, are university full-time faculty. This includes, for instance, Dr. Limry Lovell, who is an emergency medicine specialist in the emergency room. I've already mentioned Dr. O'Shea, and many others in the specialties across the hospital. A brief scan of the medical staff allocation in 2025 suggests that almost 20% of the consultant staff at our hospital are UWI full-time faculty. And so I want to make it clear the contribution the university has made to healthcare and the value that we have done in terms of bringing healthcare in an innovative space. I also echo the minister's suggestion that the transplant bill is really at a critical point in Barbados that we never wanted to get to. But because of the burden of non-communicable diseases and the lifestyle changes that have occurred, we have arrived here and we have to treat with them. The minister also went on to mention the responsibility of individuals and the fact that we all need to take responsibility for our health actions and what we do. I certainly will not be having any added sugar at lunch today. I never do. And I will be watching to see who adds salt at their table as well, including brown and white mints. Or blue. But Madam Deputy President, this is a serious bill. And so let me start by congratulating the government on the initiative, because Barbados now joins a growing list of nations that have recognized transplant is part of modern medical care. We all in this room will know the tales, and I have had this personal experience of seen a relative pass. And days before passing, her closing words were, "I am going back to my maker, however I came." This is this is almost a personification of who we are as a nation. And it speaks to our religious background. We now have to change our entire culture, and we know how changing culture can be difficult. How do we change that culture so that the average Barbadian citizen doesn't see this as an act against God, but sees this as the ultimate act of giving an organ to another person who may need it? As a physician, I have actually witnessed the gift of life. Today, I will return to the hospital after a few months' break in university exam season, and I am sure, even just by scanning the list, and there's a nephrologist behind me, several of the admissions will be dialysis-related complications. They will be in the emergency room, waiting for some time. Many of them will be on the wards, waiting for weeks, and shall I also say sometimes months, waiting for access for dialysis. This isn't just a person in hospital, but this is a family member making daily visits to hospital, seeing what is happening, hoping for good news, for instance, an infection clears so they can finally have a procedure done, or that something else has popped up that has further delayed it. Minister mentioned, of course, the lack of, or the need for more specialists in various areas. Well, there is only one transplant surgeon, and even if she were to do organ transplantation, she can't kind of create another person there on the spot. So there's one transplant surgeon. We need more. We certainly need more nephrologists. When I did my nephrology rotation as an internal medicine resident, I recognized firsthand how difficult nephrology was. And I have to say, Dr. Jurawan is my classmate. It was the first subspecialty I crossed off my list because I thought it was way too difficult to really continue in a career. Nephrology and dialysis patients are special patients. They're difficult to manage. They require, too special for me, although they use a lot of drugs, which is pharmacology. They require a whole of hospital approach, from nutrition to social services, infectious disease, internal medicine. It's not just someone coming in for a few days with a cough or cold or even heart failure that comes in and goes out. And so I really want to also, before getting into the bill, draw attention to the atmosphere, or let me just say the environment that the dialysis patient faces at the Queen Elizabeth Hospital, because I haven't visited SILS recently, so I have to speak to QEH. Tomorrow morning, en route to the hypertension clinic, I will pass the dialysis unit. Minister, you may be surprised to note that as I pass this unit in the corridor will be vending machines. And even as we begin the national conversation of changing the environment, I can't help but wonder that the hospital is a health space. And if we can't get this one space right, then how do we speak to the wider environment? The vending machines will have different colors drinks. Some will be carbonated with red labels. This is next to a dialysis unit. As I walk past these vending machines, which I'm sure the hospital will treat swiftly with the new board, there have been several lamentations happening with the quality of the products in the machines, the quality of what is on sale in the cafeteria, but still the status quo remains. And I would like to see tomorrow morning at around 8:30, as I walk past, that these machines are sanitized in a very careful way. There are dietitians on staff. There just needs to be the will, I will not say political will, to make the change. As I walk past the vending machines, I will see patients waiting to enter the dialysis unit, not at dialysis, and I have to say it's a very comfortable unit. I have been accused of being there occasionally on the pretense of seeing a patient, but they have a good coffee machine and everything. But it's a good unit. It's air-conditioned. Madam President, not that I'm wishing anything on you. If you wanted to be in a place in the hospital, it would be a dialysis unit. But this is not different from any other dialysis unit around the world, because we recognize people are giving up 2 and 3 days of their life to come to this place, and it needs to be comfortable. We can make it more comfortable. My concern, however, is that group of people who are sitting outside, and the school in St. John, we used to call it the bench, sitting outside on the bench, waiting to get into the dialysis unit. To me, I find that is difficult to consume. In a hospital where we could easily have a dedicated space, a lounge area where these people can sit with dignity, no one has to know that you're having dialysis. As patients, orderlies, relatives, everyone walks past. It is not a shame to be on a dialysis machine, but again, everyone deserves their privacy. Everyone knows that those people sitting on the bench are waiting to enter dialysis. Think about the impact that has on the 27-year-old who must sit on the bench, waiting to enter the dialysis unit, when all of his friends who may be coming to medical patients for other reasons are there and seeing him, and therefore they know his diagnosis. So what I hope to do is really to highlight, Senator Goodrich is not here, but I am also going to strongly support the bill, Madam President, by highlighting some of the strengths, because the average Barbadian may not recognize the strengths in this bill. First of all, the consent framework. I am no legal person, but I have to say, I have never seen such a tiered consent process even in existence in our hospital. It really has multiple layers of consent, and it follows the principle of medical ethics relating to autonomy, and it reduces coercion risk. So that is one strong area in the framework. There is an anti-commodification statement there throughout the bill again. There's absolute prohibition of tissue trading, sale of products, and I believe there's a fine in there as well of 500,000 Barbados, or a 7-year penalty. To me, the penalty could have been stiffer than that, but so there's the highest criminal deterrent is in the clause as well. There is an independent counsel, the third strength there again, with a bioethicist, legal representation. What many councils similar to these do not have, but this one has, is a patient representative, because many councils speak to the management of patients, and sometimes we forget to include those people who we are speaking about. Nurse representation and a community NGO. I assume that this NGO will probably be from the Barbados Kidney Association, but any NGO I'm sure will be there. So it's multidisciplinary. So you have diverse oversight and various checks on power. There's a non-discrimination clause as well. There's no denial of registration based on medical diagnosis, unless the indication for dialysis states this, that there's no contraindication on medical basis or disability. Death determination, again, two-doctor confirmation is required. It's quite detailed, the absence of circulatory signs as well as brain death. We have confidentiality in there. Senator Goodrich alluded to this by stating that she wanted to ensure that there was confidentiality. I think the bill speaks to this. The hospital in its modernization, I am sure, will treat with this matter also as it moves from its paper records to an electronic format. How will these data be secured and protected? And of course, the other minor protections are there, and public education. Council has been given a strong mandate to be involved in public education. But the minister may be pleased to hear me say this, that I think that this responsibility really needs to shift to civil society as well. Civil society in our role, and notice I'm saying in our role, because I'm a member of civil society organization, must treat with public education. We cannot just be in the government space lobbying and advocating for policy. That's important, and I get that. But we have a strong mandate as well to speak to the people who we represent, the many patients and families, and start the education process. And so what I would want to see as early as next week, I'll give you the weekend to consider it. What are some of the public education engagements that the Barbados Kidney Association will have that speak to this bill? How are you beginning to sensitize patients? Within the university, for instance, we will have to work on sensitizing healthcare professionals, doctors, but of course nurses and all healthcare professionals on transplantation. Transplantation is a touchy issue. It's a touchy issue when it's being introduced, and sometimes it just takes one bad case to spoil the entire algorithm of rollout. I've compared this bill to the gold standard I consider. I have to say I have a bias because I did part of my training there, but the United Kingdom Human Tissue Act of 2004, which is really one of the most comprehensive pieces of legislation dealing with transplantation, in my opinion. Madam President, it was born really out of tragedy. Elder Hay and Bristol Royal Infirmary scandals, really in the late 1990s, where organs were retained from children without parental consent, caused a scandal, and with that scandal came strong legislation. So Barbados has the advantage of legislating this 22 years later with the benefit of these 2 decades. If you were to compare the bills, though, and this is really not to say that one is better than the other, but perhaps highlight that one is more matured in a society that is more mature in its consumption of transplant. the governing body. So again, we have the National Transplantation Council, which is multidisciplinary. The UK has the Human Tissue Authority. Same thing, it's an independent statutory regulator with licensing, inspection, and enforcement. Consent model is there. The difference between Barbados's consent model and that in the United Kingdom, as the Minister alluded to as well, is that we are an opt-in consent. Now, this is something that could cause a lot of debate. Why opt-in versus opt-out? The opt-out concept is where you opt out of not donating your organs when you are deceased. Opt-in means you have to state this clearly before that you want your organs to be donated. I heard the Minister has publicly declared on national television without consent. So these things occur, and you might wonder, why have we not gone with an opt-out clause? Because then you get more transplant organs available for use. It has to do with changing the culture. You can't bring a new legislation that's dealing with transplant and say, oh, by the way, from tomorrow, by default, every single Barbadian citizen must opt in to have their organs transplanted. Many of us will rush and maybe call the licensing authority, because it's usually tied to your driver's license, and say, well, wait, I ain't ready for this yet. I need some time. And so having this time, and I started by saying 2 decades occurred in the United Kingdom, allows transplantation bills to mature. I have no doubt that in 20 years' time, when many of us in this room may be the beneficiaries of this bill, who knows, that we probably will be in an opt-out environment. Licensing regime is there. Codes of practice are quite similar as well between these two bills. Nominated representatives, next of kin hierarchy is defined very carefully in our bill. In the United Kingdom, the individual may formally nominate a representative. Another gap that I have identified, and I think this is something for us to consider in the 2026 bill, is DNA. Who protects the DNA? With organ transplantation comes the movement of tissue, and with tissue comes the movement of DNA. Where is this DNA going, and what is it being used for, and what bad potential could it have, for instance, if our DNA got into the wrong person's hand or organization's hand? There's organ preservation. Our bill doesn't really speak to an explicit provision for preservation, steps pending consent, and I note that in one part of the bill it mentions the approval of the coroner, but that process may take time, and in terms of transplant time, hours means loss of transplantation. So how is that process going to be expedited? I assume that we will use technology more to expedite these processes. There are many similarities, but the key observations, however, I have mentioned, the independent regulator is important. I wasn't quite clear in the bill who the qualifications of the transplant officer, but I assume that this person will have some kind of medical training. I know the current officer is a nurse, so there's obviously benefit there. It doesn't have to be someone, doesn't have to be a nurse, it could be someone who's very much aware of the health system. The important thing is that that person cannot or should not be involved in the care of the person being transplanted, because that is, of course, a bias, and this is something we have to be careful about. I note that the CMO can recommend to the council that that person could be removed, and I couldn't help but wonder whether that could produce some unfair pressure. For instance, the transplant officer may be rejecting a lot of transplants. The CMO may not like that and could recommend, if that is a possibility. But I understand why the structure is the way that it is. Of course, like many bills, its development will depend not only on the public education, but as the minister stated, the resources that evolve to support where the bill will be housed. So for instance, immunohistochemistry. I'm not sure if they still measure drug levels like tacrolimus and all the other drugs that are done, but I remember as a resident, these used to be difficult things. You do a transplant, and you can't get the levels of the immunosuppressants back in time to adjust drug levels. Again, pharmacology playing an important role. And of course, genetic testing with HLA. These are things that you can't send overseas and get back days or weeks later. You need faster results to make clinical decisions. And so my priority areas for the bill would therefore be its continued and evolving protection of minors as donors. The registry security, how is the registry going to be secure? The donor and transplantation registry contains extremely sensitive information. How will this be protected, especially in our cybersecurity environment? What steps will be taken? Allocation principles, delegating the necessary staff and resources. As I said, one transplant surgeon cannot run a transplant team, and we will need to look at this moving forward. And I did not know these data, but according to what the minister has stated, 4 nurses per consultant. That's quite a lot, considering that you mentioned only 25 are graduating from the Barbados Community College for whatever reason. Of course, I've already mentioned the coroner concurrence, again in section 28 of the bill. How is that going to be expedited? Because you really need a fast turnover in decision making in this case. Many of us have had interactions with the coroner's office, and we appreciate that some delays do occur. There are some overarching ethical considerations, Madam President. Transplantation medicine, for instance, raises questions about the statute cannot fully kind of speak to, but the law must at least acknowledge them. Commodification is one, prohibition of tissue trading, but commodification may be more subtle than we think. Financial incentives for those people who donate, even disguised as compensation for an inconvenience, are things we need to guard against and erode really the voluntary principle of transplant medicine, really. On equity, a transplant system that even unintentionally advantages well-connected is morally unfair. Can you jump the transplant queues, for instance, if you know someone on the council or if you know someone in the administration? How is that protected? These are principles that are well spoken to, at least in the UK model, where queues are very strict. And I know this because I've had several patients who have had to be on transplant lists in other countries. I want to close, Madam President, by really commending the work that has gone into this legislation. I know it has been done, not always with surgical precision, but it has been a lot of work that has gone into it. And it is evident from the quality of the final product. But I want to speak in closing to those patients out there who have been told that they may need dialysis in the future or are at risk. Maybe they have a high HbA1c that the leader of government business has stated, or maybe they have hypertension undiagnosed. Many of us in this room, statistically a third of us, probably do have hypertension undiagnosed, right? To drive home, this is not me advertising because that's illegal, but to drive home the principle even more, 80% of people in this room will die from a non-communicable disease. 80% of us. Of course, the other 20%, your options include things like gun violence or motor vehicular accidents. So we all are going to die. So it's really what we will die from. All we're doing here is trying to prevent premature death. So my final plea is for a dedicated space for dialysis patients with some dignity. A nice curated space somewhere, air conditioned. I wouldn't say a coffee machine, but yes, security and basic amenities, because this is a long wait and sitting on the benches is not satisfactory. The QEH must also sanitize its health environment so that the environment that we present to these people coming for transplant or dialysis matches what this bill is meant to do, to say that we're trying to improve the quality of care along the disease spectrum. And also to immediately address the available options for vending at the hospital. I urge all physicians and medical staff involved to view the bill as developmental. Don't think it will capture everything at once. Many of us in medicine are accused of criticizing every bill because it's new and we find gaps in it. But see this bill as a starting point and not the end or a destination. Madam President, there are many of us out there who are at home celebrating this debate. Some of us are in the audience and doing so silently. It has taken a long time, but it has arrived at a time in our health history that is absolutely critical. We can no longer be satisfied with the old adage that we have to go back to our maker as we came. Our altruism must now evolve to a point where if we can give the ultimate sacrifice of an organ, whether alive or when we've passed, this is something we have to embrace as Barbadians. And to show, and this is shown in this bill. And so, with those words, Madam President, I strongly support this bill on behalf of the many families, patients, healthcare professionals, support services, and again, the future of our country. And I'm much obliged to you.
Thank you very much, Senator Dr. Connell. Senator Aline, please.
Thank you, Deputy President. Rising after those sober warnings from my friend Senator Connell as to my mortality and likely course of life, I am reminded, however, that this government, and I believe the Minister of Health would have highlighted recent pieces of legislation, such as the medical products bill. This government has sought a holistic view as to how we are going to improve and impact healthcare in this country. And this is not something that is new. I do not believe it's an exaggeration. I actually dare say that I believe this piece of legislation is as impactful as that legislation of April 1980, when the Barbados Labour Party government introduced the National Health Drug Service, in terms of its impact on the ordinary average man. And in terms of that impact, I think it's sort of reflected today in terms of this gallery. In my short period in this chamber, I don't believe I've ever seen our chamber as populated by visitors in the manner it is today. And I think that speaks to the interest of the average Barbadian in this legislation and the impact of this legislation on the lives of the average Barbadian. The Honourable Health Minister spoke of our increased life expectancy blue zone. I think we're only second to Japan, so that piece of information shared in terms of persons hitting 100 years old. But I am also concerned as to other information which speaks to the fact that as we get our increased life expectancy, we aren't necessarily increasing the quality of that increased life expectancy. We are living longer, but not necessarily in a manner where those years are treating us well. And in a society that is as plagued by NCDs as we are, obviously that is more prevalent in the context. Those longer years need to be of the quality we would want for the average person. And when the health minister spoke of getting your checks early, doing your tests early, that is the only way that we can impact it in terms of our personal responsibility. Living longer in a substandard state is not our goal. And I think this transplant bill offers the opportunity to impact the quality of that extended life. it is not hard to understand that the quality of life of a person who has to attend dialysis 3 or 4 times a week will not relate or compare to a person who has the benefit of a transplant in terms of a kidney and actually can have a normal existence. But I've spoken to the fact that this impacts the normal man, the average person. Recently, a friend who I had not seen in quite a while told me of being diagnosed with kidney failure. He was extremely positive in outlook, and a major part of his positive disposition related to some of the services which presently exist in this country to assist those who are dealing with those afflictions. Subsequently, he indicated to me that he is set to have a transplant based on the fact that his sister is a match. And they're going through the procedures to put it in place that he can have that transplant. His experience, the opportunity he has, to the best efforts of this government, has to be the opportunity for every person who is so afflicted. And that opportunity must be balanced, fair, and equitable. I think one of the strengths of this piece of legislation is that it has set up the dynamics and structure where we can see that there will be an equitable effort in terms of how persons can access the benefits of transplants in this country. The playing field has to be level. It can't be that the persons looking on expect or view a situation where those with the greatest resources are the persons who will have the greatest benefit in however we set up this structure. We have to be able to ensure that the person of humble means and capabilities has the opportunity as any other individual to access the benefits of our transplant legislation. And I think the legislation does an admirable job in setting up the safeguards in terms of the council, which will review the registry which is being established in terms of donors and recipients. It has put the structure in place to safeguard the elements of equity. And my friend, Dr. Connell, equates it or compares it favorably with what he considers to be the lodestar of such legislation, that is the British legislation. And I'm heartened because I'll be guided by the professionals as to whether we have done a good job. And from what I understand, this legislation has been informed by the professionals. It has been a long time in coming, but it has been a process that has been painstaking and comprehensive, such that the product at the end of the day is a product that we can be proud of. So that when I look at the legislation and I note the manner in terms of allocation of organs, selection of donors, the consent provisions, it is a strong piece of legislation. I do not know the standard relative to the issue of minors, and I will admit that as I reviewed the ability of minors to consent to donation, it is limited to regenerative tissue, and I think that is appropriate, especially in a situation where parents may be the ones who are being the receptors of the benefits of the transplant, and they're the ones given certain consent. Yes, covered by the nature of medical information, but I do think it appropriate that it should be limited to regenerative tissue in the position in terms of minors being the donors of tissue for transplant. Again, the strictures have been placed in terms of trade in human tissue. Yes, we are setting up legislation which matches the best case scenarios of first world countries, but we are not immune from the practices and the nature of human as we are in the context of how we deal with life impacting decisions. Persons, when they have to deal or consider their mortality, do not have the moral strictures that we would sometimes wish to be displayed. And as I have indicated, when resources are no longer a limitation on your actions, we can get some of the worst practices of human nature. And I recognize that this bill has taken a considerable effort to control and make sure that we put the necessary offenses and limitations on that behavior. This piece of legislation, as I said, follows a long list of revolutionary type legislation which has impacted the quality of health care in this country. And I don't believe that this bill is in any way of any lesser impact than, as I said, legislation such as the drug service implementation. I am proud to be standing in support of this legislation, and I can only hope that the type of impact will rebound to the average Barbadian, their families, and the persons who are impacted by the covered diseases. Thank you.
Thank you very much, Senator Ali. Speakers? The Honourable Attorney General of Barbados.
Sorry, Madam Deputy President. I rose before you indicated. You let me to sit back down.
If you wish the exercise,
It's a health bill, so you could movement.
Madam Deputy President, I am glad to be here today in order to cast some light from a legal perspective on some of the terms and conditions of this bill, to support the Barbados Kidney Association. And more than that, ma'am, I did not ask for permission to call the name, but everybody has been so free with names today that I am going to ask for the permission to call the name of Dr. Margaret O'Shea. I know. I did not ask for it before. Madam Deputy President, I have known Dr. Margaret O'Shea since I was 11 years old. That would make it, I think, like 80% of my life or more. And Dr. O'Shea is a furiously independent person. And in my whole time knowing her, she never asked me for anything except this. A couple of years ago, when Dr. O'Shea came back from, I think it was Australia, she went to do her studies and specialty in this area, transplant. And she came back as a renal surgeon. I think that's what it was. I didn't even know what a renus was. I became aware of what renal surgeons did and the import of it through Dr. O'Shea. And from then, I can't remember how long ago that was maybe 20 years, 15 to 20 years ago. From then, Dr. O'Shea was on about the need for tissue transplant legislation in Barbados. I was, I believe, the president of the bar at the time, and she wanted the bar to rise up and represent. When I became a senator, I don't even think the ink had dried on my appointment before she insisted that I fight this cause. And Father forbid, Madam Deputy President, when we actually came to government, she pointed out and she used the guilt trip. I have never asked you for anything in my life. If you can't do it for me, do it for all the people who do dialysis. And I got the facts and figures. And I thought, my friendship is at risk here. I have never seen somebody more on a crusade for one thing. And I started to fight for it. Madam Deputy President, and then I became the Attorney General. All I would say is for every patient who's ever had dialysis in Barbados, for everybody who suffers with kidney complications, for everybody who needs a transplant, the single most dominant voice in this area, the crusader for this cause is Dr. Margaret O'Shea, and I wish to recognize her contribution. I'm sure there were others, but I speak to what I know. Madam Deputy President, some concerns were raised by Senator Goodrich during her excellent, well, she's not even here.
She's there.
Oh, sorry. I wouldn't want to praise you in your absence. I would have stopped right there. During her excellent presentation, the presentations all around were, I think, quite solid, but I think it's necessary to address some of the actual terms of the legislation so that the public who is listening in and the press, when it carries it, can do so and allay certain fears that I know exist in relation to the public. Let's go to the definition section. The definition section defines a guardian, and I'm going to define this now because this comes up a number of times, especially in relation to the child. A guardian under this legislation means a person who is acting as guardian ad litem in relation to a minor, and ad litem means under the force of law. So they're acting as a guardian for minor, or a person who is incapable of acting, making decisions, communicating decisions, understanding decisions, or retaining the memory of decisions by reason of mental disorder and inability to communicate. And this differentiates it from in loco parentis. In many aspects of our legislation, persons in loco parentis can make certain decisions in the best interest of a child or whatnot. In loco parentis means you don't necessarily have the force of law, but if I'm the aunt and the child living at me and the child always at me and I feed the child, then I could go to school and represent the interest of the child and whatnot. For the purpose of transplanting and giving consent to transplant or to donate tissue, we're not going anything so casual as in loco parentis. It has to be a parent or somebody who the court has appointed and they have the force of law as a guardian. The other one that I'm going to touch on now, because we referred to this a couple of times, is the difference between regenerative and non-regenerative tissue. Non-regenerative tissue is defined first, and it says simply, tissue other than regenerative tissue. Regenerative tissue, where we get the context from, means tissue that after injury, within or after removal from the body of a living person, is replaced in a person's body by a natural process. Probably closest thing I can think of that regenerates itself in a lot of us is fat. But the point is, the point is, the bulk of the discussions here and the bulk of this legislation concerns regenerative tissue. And that's probably the easiest thing to actually donate or to transplant. Something that's going to grow back. If you have it and it's going to come back, I don't know, skin. I'm not a medical doctor, but things that the body will naturally replenish itself of, as opposed to, for example, a kidney. Now, they're set up under this legislation a council, and the functions of the council are settled in Section 5. And they are to advise the minister on changes and proposed changes to the legislation governing human tissue transplantation in Barbados, and to provide advice and guidance to the medical practitioners engaged in human tissue transplantation on issues that arise in the allocation of organs to recipients. So, Senator Goodrich, this is addressing one of your concerns. The selection of donors, propose new or novel programs of transplantation in Barbados, and removal of tissue after death. They also to approve the qualifications, experience, and character of persons proposed for appointment under the Act, to inquire into and report on any issue related to human tissue transplantation, to consider and advise on any matter related to human tissue transplantation as brought to his attention in writing by a member of the public, or to seek advice on any matter relating to human tissue transplantation from any source, whether within or outside of Barbados. So this council pretty much is a supervisory and advisory body to the minister. So for the public, all concerns that you have in relation to this, you're free to ventilate them or make them known to the council. The council will consider and make advice to the minister. The minister can also seek the advice of, in this case, her own volition. But pretty much any concerns that are raised or that the public has in relation to this legislation can be raised with the council, and they can be taken into consideration in advice to the minister. Now, we get to the meat of it. Senator Goodridge also raised the issue of the keeping of records. I think your actual phrase, which was startling to me, was proper record keeping in the aftermath. I would like to think that the aftermath usually considers what happens after disaster. I would like to think that we would not use words like aftermath in relation to this, but I take the point in respect to the record keeping, the proper record keeping. And there is, under clause 7, the establishment of a registry. And this registry shall contain the following information: names, address, and contact information of each donor, and a record of the consent given for the tissue to be donated and any amendment or withdrawal of such consent. So that addresses, in one, the concern that you stated in relation to the keeping of the records for the consent. Now, the registry will also contain a record of the name and address and contact information of each patient awaiting a transplantation and the tissue involved, the name, address, and contact information from each patient who received a transplantation and the tissue involved, and any such information as the minister considers appropriate. So pretty much everything in relation to the process for transplantation, who is donating, who is receiving, and the minister has the authority to ask for any other information. But I think this provides the framework for capturing exactly what it was that you wanted. Now, at this point in time, I did note that the record of the consent is a lot harder to achieve than the retraction. So the consent has to be evidenced. I know at one point in here that, Madam Deputy President, I think in relation to donation of tissue after death, I think you would have had to evidence the consent of the person by one witness. I think that is something we may wish to relook and possibly amend in committee with the consent of everybody else. That to keep this in line with the Succession Act for gifts, because really and truly, if I'm consenting to a donation, that's a gift of my body to you, and it should follow, as far as I'm concerned, the terms of the Succession Act. So I think we should probably use 2 witnesses for this. There are 2 witnesses provided further for something else in here, and I think that's an easy amendment that would satisfy certain persons. And you know what? I think measure twice and cut once, because the consent must be certain and should not be questioned. And as difficult as the consent is for those persons, and you raised as well, Senator Goodridge, in relation to the consent, the withdrawal of consent, and vulnerable persons, while you have to toe the line in relation to signing and having witnesses for the consent, and the consent being required a couple of times, right? You can actually withdraw it in an oral statement. So I could have signed twice, I could have given the consent right before the surgery, and at the moment they're about to put me in, I could say, I'm not certain about this. And that's sufficient. You withdraw it and you go again. So in relation to the vulnerable and to persons taking advantage of persons, a person can withdraw their consent at any point in time before the surgery, and although the consent was given in writing with signed witnesses, you can withdraw that consent orally or by a gesture if you're unable to communicate orally. Now, I am proud and pleased to see that embedded in the legislation itself, you don't normally see this embedded in legislation, this usually follows the fact, is a public education program under Clause 8. I think we recognize that this is a culture shift for Barbados, that we're going somewhere that we have not gone before, and once again, because of the activism of the Barbados Kidney Association, because of the activism of the same Dr. O'Shea, I think the public has been primed for this time. This has been a long time in coming. I think the public is now sensitized to the need for it and is willing to accept it in a way that they probably would not have, Dr. O'Shea, when you started your crusade some 15 years ago. So I think we're at that point in time now where the public is prepared to accept it. However, it was wisely decided to embed in the legislation itself the need for public education program, and it says thusly: the council shall establish a program to educate the public on A, human tissue transplantation and its uses and benefits, and B, the importance of registering for the donation of tissue. So it is incumbent upon the government, through JS, through all of its organs, to actually spread the word about human tissue transplantation. Once we pass this, it needs to go. These are your options. This is how it benefits people. It should not be a mystery. People need to understand that, quite frankly, they say you can't take anything to the grave, right? You can't take anything to the grave. Why would you take something that's of use to somebody else? I had a sidebar with the Minister of Health, the Honourable Minister of Health, just before speaking. Actually, I was in the process of laughing, Madam Deputy President, when I realized it was my turn to speak. I said, well, for any time they do the registration for organ donations, I plan to be the first person to sign up in honor of my friend. I said, I plan to give away so many things that when finished, you could bury me in this box. So my firm belief is the best gift you could give somebody is of yourself. It is hard to do. It might be hard for people to contemplate transplantation while they're alive. They may not want to give up any of their organs while they still have a use for them. You might not want to give a kidney because you're frightened that if you give a kidney, then you might find yourself, I'm not even going to tell them what you were laughing at. I'm going to retain your dignity here this afternoon. That people are worried sometimes that you may make that ultimate sacrifice and make a donation, and then you actually suffer a failure and have nothing to fall back on. The duplicate is not there to fall back on, right? I think that does not apply itself if you know you're coming to the end of your life, or if you set out the circumstances, because you can set out the circumstances under which you donate, right? You, the donor, is not a carte blanche. I can say, I will donate in these limited circumstances. I write up what it is I plan to donate, how I plan to donate it, and my wishes have to be told in relation to that. So persons can create whatever framework that they wish to create to make themselves comfortable. I, as one, can tell you, Madam Deputy President, I do not wish, when I'm cremated, that anything that is of use to anybody else gets burned to me. I wish that as my final gesture, and my final service,
Pre-burn and post-burn.
Madam Deputy President, I would not stand here in your chamber and ask you to censor the Honourable Leader of Government Business in this chamber, Madam Deputy President. But her mind is going somewhere I do not wish to go with her. Yes, Madam Deputy President. So, it is necessary for us to get as much of a national buy-in as we can, and this can be done through public education. And I wish to assure all who are concerned of the government's commitment to do this as widely as possible. This is not just a cause of the minister. I think the entire cabinet, the entire cabinet is in unanimous support of this legislation, and the Prime Minister herself is a champion of this. So whatever it is that's required to activate this fully and to make the public as aware as they can be will be provided by the government. With respect to the allocation of tissue, this was, as I said, you raised a lot of concerns that I wish to, a lot of your concerns are concerns that the public would have as well. So I'm going to address them here now. Allocation of tissue. The Council should establish a medical criteria for allocation of tissue and a fair and equitable, transparent system for such allocation to patients awaiting transplantation in accordance with such regulations as the Minister may prescribe. So this is not a case of donations being made or persons being allocated or bumped to the list and the haves getting and the have-nots being left out, right? The Council has the authority to set up all the regulations and all the structures to ensure that it is, and in words, it starts with a fair, equitable, and transparent system for such allocation to patients awaiting transplants. So I trust that addresses your concern. No person should be declined inclusion in the registry on the basis of a disability or a medical condition. So this also prevents, you spoke about the most vulnerable. And I have heard in relation to transplants, persons say, but why give it to so-and-so because they're already sick with something else? Or why give it to so-and-so because the disabled, right? No, the law specifically sets out that you cannot disadvantage a person and refuse to include him in the register because of a disability or a medical condition. So that addresses your concern as well as raised in relation to equity, fairness, and protection of the most vulnerable. Now, let's talk about donation of the tissue. Subject to this act, anybody can donate tissue who is 18 years of age and of full capacity, or who, if they're a minor, is married or is a parent. Now, the reason for in relation to the minor, of course, an adult can make whatever decision that they want to make in relation to their own body. In relation to minor, our law does recognize that a minor can, with the consent of their parents, be married. And if you're married, then you have certain says as a married woman that you would not have as an unattached minor. And if you are a minor who happens to be a parent, then if you have a child who then needs transplantation to help the child to live, then you, the parent, although you're minor, have the right to make decisions in relation to your body and your child. So that's one criteria there in relation to the minors, and it's an understandable criteria because a parent, a mother, will naturally want to save the life of their child, and it's something that we have to understand and contemplate, even if it's in the case of a minor, but the protections are here. And this occurs in consideration of medical advice given to them by a medical practitioner in writing and signed by the person in the presence of the designated transplant officer, and they consent to remove the regenerative tissue for the purposes so specified. I had said this before, but I will tack it back in. A donor may at any time before the removal of regenerative tissue to which the consent applies withdraw his consent orally or in writing. And you spoke as well, Senator Goodrich, about the need for people to actually know what it is that they're doing. The designated transplant officer shall, this is under clause 12.4. The designated transplant officer shall, before the removal of the regenerative tissue, certify in the form that all requirements referred to in subsections 1 and 2 have been complied with, and, Senator Goodrich, that he has explained to the donor the implications of removal of regenerative tissue from the donor's body, and the donor has consented to removal of the tissue. So the person must not just consent, but they must have informed consent. And this is not at large, this is not vague, it is the person who is the transplant officer in this instance has to fully inform the person who is donating, I think, of the possibilities as well of failure and the consequences and all the negatives, right? And that the person would have to consent. Pardon? Mm-hmm. No, that was 12.4, but don't worry. Sorry, 10.4. Apologies. Donation of non-regenerative tissue by adults. Please note that there is no provision here for the donation of non-regenerative tissue by minors. So an adult can make a decision to donate non-regenerative tissue, something that's not going to grow back. You can make that informed decision. I wish to give this up to save a life, but we don't put that implication on a minor. So the parent can do it for the minor. That's a decision the minor will have to make when they become 18 years old. But you can see why that is done, because it may have an enduring implication or enduring consequence that the minor cannot comprehend at the time of his or her minority. And once again, with the non-regenerative tissue, there's a form that you have to fill out, and you have to explain to the donor the implications of removal of non-regenerative tissue from the body, and the donor must clearly state, sign on the form, that he understood the implications. Part 4 deals specifically with donation of tissue by minors, etc. So we dealt with minors in the earlier sections, but there's a part that actually deals specifically with minors as Part 4, and subject to subsections 12 and 14, no person may remove or consent to removal of non-regenerative tissue from the body of a living minor for the purpose of transplantation of such non-regenerative tissue into the body of another living person or for use in any other therapeutic, medical, or scientific purpose. A parent or guardian of a minor may consent in writing to the removal of regenerative, well, it speaks to regenerative tissue, but is quite clear in relation to non-regenerative tissue. We even speak about where the minor, now, under this, although a parent can consent on behalf of a minor to a transplantation, the minor's consent is still sought because at the end of the day, you're taking something for a child. So it has to be explained to the child in language that the child can actually understand with the consequences of it. And it is limited circumstances. So I, as an adult, can decide to make a donation to my good friend, the Honourable Minister Sinclair. I know you would. I can decide to bestow upon him anything I want.
Listen.
Or any of you. However, it is very, very narrow in respect of a minor. So donations from a minor or consent in relation to a minor can be for the purpose of transplantation into the body of a brother, a sister, or parent of the minor. And this is subject to medical advice from a medical practitioner other than the practitioner who is being asked to transplant the tissue. So to avoid any possibility of undue influence, to avoid any, we spoke about corruption, persons who are seeking to benefit from this advice has to be given by somebody who is a disinterested third party who only has the interest of the minor at heart. And a medical practitioner, other than a medical practitioner tasked with the transplanted tissue certifies in writing the medical reason for the transplant. So where this happens as well, whoever is doing the transplant steps back as part of it. The advice to the minor, the certification that is necessary, whatnot has to be done by a disinterested third party, and this is to protect the minor who, as you said, Senator Goodrich, is a vulnerable person for the purpose of this. And in any event, the minor has to sign the form, and the minor, it has to be explained to the minor in terms that the minor can actually understand what is going on. All right, so we don't just make the consent on behalf of them, you have to break it down into childlike language that is suitable for their level of education and intellect, the consequences of it, how serious it is, what you're hoping to do, and to try to get the consent from that minor. So if the parent consents and the minor does not consent, the consent still does not go. So the person attempting to give the legal consent on behalf of the minor and the minor themselves must actually consent. One interesting thing that was raised here was paired tissue donation. We looked at not doing horse trading in relation to organs and tissue transplant. But however, if a situation arises where I wish to donate to Senator Sinclair and Senator Cummins wishes to donate to Senator King, but we are not compatible, and they're not compatible. But I am compatible with Senator King, and Mr. Sinclair is compatible with Senator Cummins. We can make an arrangement between ourselves for no consideration. Money cannot pass here. We cannot corrupt this. But if my intention is to help to save him by giving up one of my organs, and her intention is to help to save Senator King by giving up one of her organs, and for reasons of biology or DNA, I don't know, it just medically can't work. I can agree to give my organ across to him. She can agree to give her organ to him and bypass the list. We can do this as an arrangement between ourselves once it is not corrupted by consideration, once the money is passing, bottom line, and that's on the paired tissue donation. And I think that's a quite important aspect because it frees up people to make decisions and to try to source solutions that may otherwise be difficult in coming. And coming down to the end, Madam President, Madam Deputy President. In relation to the consent as well, Senator Goodrich, you raised a lot. In relation to consent as well, where the person has deceased, while the next of kin, if they did not consent prior to death to their willingness to donate organs or tissue, the next of kin of the person, as defined in this act, the next of kin of the person can actually consent on their behalf. However, where a person shall not give consent under this part, where the person has reason to believe that the person who died or whose death is imminent would have objected to the giving of consent. So what I can give consent on behalf of my about to die relative or my very recently deceased relative, if I know or there's evidence to suggest that I know that that person would not have wanted to make a donation, then I should not be in a position that consent is invalid. So protecting every which way. We define removal of tissue only after death. That is pretty much a no-brainer. But it's put there because we got to dot our I's and cross our T's. And the last thing I'm going to touch on is in relation to the prohibition of trading in human tissue. One of the biggest issues that's raised is that the tissue transplant framework opens up the possibility of a black market in relation to the harvesting of human organs. It's going to come up, we might as well address it here. Our law explicitly prohibits trading in human tissue or advertising in relation to buying or selling tissue. I think the fines might have to be looked at eventually because I don't know how much a kidney goes for, I don't know how much a lung goes for, but I think that the fines of $50,000, we may have to look at those in relation to raising them, because anybody who engages in that must be punished with the fullest sense of the law, and the penalty must act as such a deterrent that nobody in Barbados contemplates it. However, because of the heavy regulation that is framework in this legislation in relation to the registry and the keeping of records, I think we have adequate provisions in there that would mitigate against this, but I think we could probably look at the fines. I wouldn't object in any way to legislation going forward as it is now. You know what, nothing is perfect. Let's build and then build some more. No one should cause any tissue to be removed from the body of a deceased person except in accordance with this act, and a good faith provision for persons if we increase the fines especially, and because of the prohibitory nature of a lot of this, medical practitioners may feel, I don't necessarily want to go into this area. No, the law helps you. It's a good faith provision, exemption from liability under Part 9. No personal liability attaches to any medical practitioner or other person for anything done in good faith in the exercise of his authority under this act. Good faith provision captures all who, as they say, are operating in good faith. If you're not operating in good faith, then you're not protected by that clause. So once you're doing what your training says that you should do and acting in the best interest of your patient and with a clean heart, I think you have nothing to fear from this legislation. The last thing, the very, very last thing, is you were concerned, Senator Goodrich, about, I have never once done a speech, an address in either house that so concentrated on the response of one particular person. So I thank you for that. You made it simple for me. In relation to the disclosure of information, nothing, notwithstanding any other law to the contrary, this is clause 35, and subject to this section, no person shall by any means whatsoever make known to the public the identity of another person from whose body any tissue has been removed for the purpose of transplantation, with respect to whom consent or authority has been given under this act, or into whose body any tissue has been or is being transplanted. This is, of course, subject to any court order. Now, the reason this is done is I remember there was that case in the United States where a convicted murderer had agreed to donate his organs, and his organs were transplanted. Something was transplanted into the body of somebody else, and it then came out, and that person was subject to ridicule that they're going parts from a murderer, right? So you think to yourself, do we really need something do we need to spell it out explicitly? Yes, sometimes you actually do need to spell it out. He who is donating, his identity should be kept private. Ye who has received, your identity is also protected. And this is another practical one. If you are an organ donor, you don't necessarily want everybody to know that you're an organ donor because you wish to reach the end of your life naturally and not inspired by somebody else who has an interest to serve in some parts that you have not used properly. Madam Deputy President, I trust that I have taken us through the salient parts of the legislation. I tried to address the concerns raised by Senator Goodrich and also some raised by other people to me and ones that I've heard from the time that Dr. O'Shea started to introduce me to this area of medicine. I apologize if my medical terminology has not reached the standard of a number of persons in here, but I am a lawyer by training and not a doctor. But from what I see here, legally, in respect of this piece of legislation, I think this is a watershed moment for us. We have never had anything like this. It has been a long time in coming. There are a lot of people in Barbados who've been suffering without an end in sight, and this provides some light at the end of the tunnel, and it also allows us to think. We're not living just for today and for ourselves. Let us think down the line as to the best that we can do, the good that we can do, not only while we're living, but even after death, if we can help somebody when we've left this earth. So for all those reasons, I clearly, Madam Deputy President, I'm in support of the legislation and I endorse it as such. Thank you.
Thank the Honourable Attorney General. Senator Cummins, please.
Thank you very much, Madam Deputy President. I rise to beg that this sitting of the Senate be suspended for lunch until 2:30, until 3 in the afternoon.
Well, the question is that the session be suspended for lunch until 3 o'clock this afternoon. I see the celebratory faces. The Leader of Government Business has allowed for a whole extra 15 minutes. All those in favour? All those against? The ayes have it. The House is now suspended.